We're pleased to welcome today's speaker, Laurie Beyer, who will guide us through the key changes, implications, and what you need to know about the AHEAD model.
All right, good afternoon. I hope that all of my colleagues today will find this helpful as we learn about the AHEAD model, which is going to mean for all of us going forward. So the first section will really focus on a brief overview of the model. The second will deal with revenue and financial implications, how organizations can get ready, and then practical preparation steps. So again, as most of you know, the AHEAD model is another signal and perhaps one of the clearest yet, that CMS continues moving the healthcare industry towards global revenue, cost containment, and health equity. So, key questions that you guys need to think about today. Is your organization structurally prepared for this? And where do you need to focus over the next year and a half before this model goes live? Next slide. So, Linker, do you want to kick us off with our first poll question?
Absolutely, Laurie. And what we want to do here is basically kind of get a gauge of how you are, familiar with the CMS AHEAD model. So you'll see a poll pop up here in just a second. So we want to see, are you very familiar, somewhat familiar, vaguely familiar, or what the heck's ahead? And then D is a totally fine answer, and we're glad you're here because you're here to learn. So I'm guessing a little bit of B and C, Lori, but we'll see as we go out. We'll give everybody about 30 seconds or so here more.
Okay.
Yeah, trending that way. And once again, what's ahead is great because we're glad you're here and Lori will be able to provide you some references. All right, we're going to end our poll here. Should share this with you guys. Should be popping up screen. So we have very familiar. We got a few folks near experts. That's great. Somewhat 16 or 50% vaguely familiar. And then what's ahead? That's what we're here for, guys. It's about 20%. And Lori, we did have one question pop up and it said, how will hospital charge masters need to be modified, if at all, to become compliant with the AHEAD model?
Yes. So as of now, and again, this is what we know, we believe that the current charge masters will stay intact. But again, that could change over the next 18 months. But for now, I think hospitals just maintain the current charge master that you have.
Gotcha. Thanks, Lori. Back to you.
Okay. So next slide, we're going to go through the model overview and policy direction, just a couple of slides on the AHEAD model. But the real meat and potatoes of the presentation will focus on the revenue and the payment implications. So the model represents our next phase of healthcare reform policy here in Maryland. Again, focusing on cost control growth, improving population health, and a new feature to this will be expanding primary care access and making the state accountable for that. So understanding this new structure and the policy direction will provide important context for how payment, care delivery, and accountability will evolve for hospitals and health systems in Maryland. Next slide. So what is AHEAD? So AHEAD, it stands for, it's a long acronym, Advancing slash Achieving All Payer Healthcare Efficiency Through Accountable Design. Lots of words. Launched by CMS through the Innovation Center, which will govern us in Maryland for the next 10 years. The amended and restated agreement was signed in November of 2025 and has notable changes from the original agreement that was developed about 18 months prior. And again, designed to address unsustainable healthcare growth, restructuring how revenue will flow, and how accountability will be measured across all payers. Again, we're talking about reducing costs, which we've all been working on over the last 10, 15 years, improving outcomes, and increasing accountability. So it will combine state level accountability, prospective hospital global budgets, which we've all been working through, primary care investment, and embedded equity expectations. Next slide. So before moving forward, it's important to place the AHEAD model in the proper context. And I know many of us on this call are from Maryland, but AHEAD is actually a nationwide initiative developed by CMS. Maryland will be the first state implementing the model. And it's largely because we have significant experience with alternative payment models through the all payer model, i.e. GBRs, which operated from 2014 through 2018, and then the total cost of care model, which combined GBRs with the goal to reduce total cost of care. And that governed us from 2019 to 2025. So the AHEAD model then will build on the lessons learned from those programs. Other participants will follow Maryland, including Cohort 2, Vermont, Connecticut, and Hawaii, and Cohort 3, Rhode Island, and 5 counties in New York. These states and regions will begin implementing elements of the model over time. Most of the major policies under AHEAD will take effect January 1 of 2028. Between now and the end of 2027, the state and hospitals are in this transitional period where policies, methodologies, and operational requirements are being developed and finalized. And I want to emphasize that this transitional period that we're in now is critical. It gives you time to evaluate your systems, update processes, and prepare strategically that will come when this model is implemented in 2028. Next slide. So again, the AHEAD model builds on core elements of our system, but it also introduces several important enhancements and changes. AHEAD will maintain hospital global budget structure and quality metrics across all payers. However, there will be differences in how some of these budgets and policies are structured and compared to the total cost of care model that we were previously held accountable to. AHEAD will place a stronger emphasis on primary care investment. The model will establish targets for primary care spending with the goal of improving access to care and strengthening the role of primary care and managing patient health. AHEAD will include more extensive population requirements, which I will discuss shortly. And again, the AHEAD represents the next evolution of healthcare payment, ... All right, so now that we've discussed the goals, next slide, of the AHEAD model, this next section will focus on revenue and payment implementation. While the AHEAD again will maintain Maryland's core global budget framework, it will introduce some significant changes that will affect how hospitals are paid, particularly for Medicare fee-for-service reimbursement. In this section, we'll walk through what we currently know, how global budgets may change, and how cost growth and savings targets will be incorporated into the model. And we will discuss some areas of financial impact for hospitals and what you should begin thinking about now from a financial planning and operational perspective. As with many elements of this model, details are being finalized as we speak, but understanding the general payment implications is going to be critical for hospital leadership. And I need to emphasize, you need to get your board of directors educated to make sure they understand the implications of this model, what it's going to mean to hospital finances, what it's going to mean for your finance teams, and then the planning that's going to need to happen as we move forward. Next slide. So under the AHEAD model, Maryland will be required to meet 6 statewide accountability targets. The first one is the all-payer total cost of care growth target, which in a nutshell measures how overall healthcare spending grows across all payers in the state. And again, this target will help us make sure that we stay in compliance with the AHEAD agreement with CMS. The second target is the Medicare fee-for-service total cost of care growth, which will track spending for Medicare beneficiaries. The next two targets will focus on primary care investment targets. And again, this is new for us. I know that many of us have invested in primary care, but now the state of Maryland is going to be held accountable for investing in primary care. So the first one will focus on Medicare fee-for-service primary care investments. And this target will encourage us and will make us increase investments in primary care over time. The second will be an all-payer primary care investment target, which will apply to all payers. And again, intended to strengthen the role of primary care in improving outcomes and preventing costly hospitalizations. The next will focus on statewide quality and population health targets, and I'll talk about that in a minute, which again, improving population health outcomes in your communities and ensuring that the model doesn't focus just on cost, but on quality. And then finally, there will be an all-payer revenue limit. This will apply to hospital revenue only. And again, this requirement will ensure that our growth in hospital spend stays within the limits of the AHEAD model targets. So taken all together, these 6 targets create a framework that holds the state accountable for cost containment, outcomes, and quality care. Next slide. Okay, so what we know. So the HSCRC will establish global budgets for hospitals in fiscal 2027, with the possibility of a 6-month global budget for July 1, 27 through 12/31, 27. Because as you know, the model will start January 1, 2028, which is midway through our fiscal year. So again, beginning in January 1, 2028, we will have 2 separate GBRs. The first will be Medicare fee-for-service GBR, which would be established by CMS. A significant change for us because, as you know, the HSCRC has established those budgets historically. The second GBR will be for Medicaid and other commercial payers, and this will be regulated by the HSCRC. Note, the Medicaid portion of the budget is still in development, and what we believe right now is that hospitals will see higher contractual adjustments for Medicaid as a way of reducing Medicaid expenditures. So stay tuned for that. Another important change relates to Medicare Advantage programs. So under AHEAD, the HSCRC will be required to implement lower rates for certain Medicare Advantage plans that meet specific qualifications, particularly those with higher concentration of beneficiaries in underserved areas. So for us in Maryland, this will include Allegheny, Baltimore City, Caroline, Dorchester, Garrett, Somerset, Washington, and Wacomico counties. So overall, this new structure will introduce greater federal involvement in Medicare payment methodology, period, while maintaining our existing oversight that the HSCRC has had on other payer categories. So again, significant change here with CMS governing Medicare reimbursement in Maryland. Next slide. So again, one of the most significant implications of the model for us is the expected reduction in Medicare revenue. This reduction is primarily the result of a repricing adjustment. So under this process, what hospitals would have received through the HSCRC for Medicare patients will be compared to those same services, how they would have been paid under the Medicare PPS system, which, as you all know, is the standard fee-for-service methodology that's used in every hospital in the United States except for us. But now it's going to impact us. If your hospital was receiving higher payments under the HSCRC than they would have under Medicare PPS, those payments will be adjusted downward to better align with the national Medicare benchmarks. Now, on the flip side here, to help mitigate some of this impact, the HSCRC approved a policy in January of 2026, allowing part of the lost Medicare revenue to be partially cost shifted to commercial payers. So, in other words, our private insurers will be absorbing some of the reduction in revenue from Medicare through adjustments in commercial hospital rates. Again, to be determined. As I mentioned, Medicaid rates will be reduced, and we think tied to Medicare, but again, that is to be determined. So while these payment changes directly impact Maryland hospitals, this is really important from a national perspective because what we do here in Maryland will, I believe, eventually influence broader Medicare policy across the United States. So hospitals nationwide will be watching us. And if we demonstrate success, which I think we will, and we have demonstrated success in controlling cost growth and improving outcomes, this model will be adopted in other states. For Maryland hospitals specifically, what I want to tell you today is financial modeling, operation efficiency, and strategic planning, which we've all been working on, but it's going to become extremely critical during this transition period leading up to the full implementation in 2028. Hospitals really need to look at how these reimbursement adjustments, particularly for Medicare and Medicaid, and for most hospitals, that could be 60 to 70% of your revenue, how that's going to impact when you have reduction in that reimbursement, how it's going to impact your margin, how it's going to impact your service mix, how it's going to impact your long-term financial sustainability. Next slide. So another set of financial implications of the model relates to how certain costs and services will be treated within the hospital payment structures. Uncompensated care, and this is really, really critical. And uncompensated care, charity care, bad debt, will be built into the base budget, your base budget in 2028. And as you all know, historically, each year, the HSCRC would adjust your uncompensated care. So if you had an increase, you would get more in your rates. If you had a decrease, your rates would be reduced. Under a head, what will be built in will be fixed. And I believe it will be based on 2023 experience. This means that hospitals will no longer receive annual adjustments if your uncompensated care changes. So this will create potential risk if your hospital or health system sees significant increases in uncompensated care. Future Medicaid assessments, and as you all know, the HSCRC has built Medicaid assessments into budgets, but these will no longer be included in the Medicare GBR. So from our perspective, this will raise an important question for our policymakers about who's going to absorb those costs, since they will no longer be offset through the Medicare portion of the hospital revenue. Some services will begin to remain outside of the global budget and will continue to be reimbursed on a traditional fee-for-service basis. A significant example includes organ transplants, which will require separate reimbursement due to the complexity and variability. Another important component, and this will be important for those hospitals that have a significant amount of psychiatric and rehab patients. We believe that those services will lose the premium payment that hospitals have gotten for those services. So again, if you have a huge amount of psychiatric and rehab patients in your facilities, you may see a reduction in reimbursement for that care. So overall, the policy changes highlight how the AHEAD model will restructure certain revenue streams while shifting risks to hospitals and reinforcing again the need, I'm going to keep saying this, financial planning and operational adjustments during the transitional period. Next slide. I love this. Medicare, we are at work. We've been at work, right? So another change will involve quality programs and primary care initiatives in our state. There is ongoing work to align the HSCRC quality metrics, and we all know this is quality-based reimbursement, QBR, to align this with the CMS value-based purchasing program. And the goal here is to really streamline to make sure that we have better alignment between the state and the feds in regards to quality. So what we believe at this point is that there will be two coordinated quality programs, one based on Medicare and the other covering Medicaid. The current Medicare performance adjustment that we all have been under will be phased out once the Medicare fee-for-service global budgets are implemented in 2028. The Maryland Primary Care Program, otherwise known as MDPCP, is currently being evaluated as part of the transition. CMS ultimately has decision-making authority over the program's future. It is very possible that the primary care ahead program will replace our current MDPCP, which again will have some reimbursement implications of which we don't know, but hopefully we will learn before we go live in January 1 of 2028. Next slide. So just want to make a note here about the Medicaid primary care program. Practices that currently participate in the MDPCP program will be required to use the Medicaid Advanced Primary Care program now. And looking ahead to 2028, when the primary care ahead program is implemented and we all know the ground rules, those practices will transition into this new model. Another requirement of the ahead agreement is that the state of Maryland must select one choice policy and one competition policy by January 1, 2027. I'm going to talk about this in a second, but these policies are designed to make sure that our patients have appropriate access to care and that it will promote greater competition within our markets for providers. Some examples could include expanding telehealth access, which we all have done since COVID. It's been a wonderful tool that we've all had. Modifying scope of practice regulations to allow providers to practice at their highest level, their license. Improving price transparency, particularly for drugs, and reducing regulatory barriers for providers, i.e., eliminating non-compete contract provisions in contracts. So again, it's important to note that in regards to choice and competition, the policies that we select must represent new actions, meaning that the state cannot simply choose policies that have already been implemented. And again, these decisions and what the state chooses will influence your future payments, how care is delivered, and provider participation as the AHEAD model evolves. Next slide. So a new provision under the AHEAD model is that the state will be responsible for establishing and meeting statewide population health targets. And these targets are what CMS calls Population Health Accountability Plan, or PHAP, another acronym for us to have to learn. The PHAP is intended to ensure that the model does more than just control costs, but that it does actually improve health outcomes across the population that you serve. So rather than measuring that performance at the hospital level, these metrics will evaluate how the entire state performs. Currently, the plan includes 6 measures in total, 5 core, and 1 supplemental. The measures will focus on key areas of population health, and the details are being worked out. One of the things I want to emphasize is that if the state doesn't meet the targets, there will be penalties applied across the state to be determined. So again, the intent is to create this accountability for improving health in our communities while also controlling cost. Overall, again, we all have to be working together on this, and I'm going to talk a little bit in a couple of slides about how we can do that better. Next slide. So this slide summarizes those 6 targets I just talked about. This was presented on January 23rd at the HSCRC workshop that we had that HFMA sponsored. So some of you may be familiar with these targets. They're organized across several domains, and the first one is population health. Each one will include a 2023 baseline, a 2027 interim target, and then a 2036 long-term target. So the first one focused on population health. The state will be tracking the percentage of residents reporting poor or fair health through CDC's Health Days Care module. And again, the goal is to improve overall health access. I want to note this one basically is maintenance. So there's no improvement target that we have to meet. However, for the next 5, there will be improvement targets that we have to meet. For prevention and wellness, this will measure how well we do with making sure our patients get their colorectal cancer screening annually. So again, looking at the percentage of individuals receiving those screenings. For chronic condition, this measure will focus on hemoglobin A1C control for patients for diabetes, with the goal of reducing those patients with poor control over time. Behavioral health, another significant target here, will track our ability to track our patients for follow-up care after a patient comes in for a mental health illness, whether or not they're getting their follow-up care after 7 days and 30 days after discharge. And as we all know, improving those follow-up rates helps reduce relapse and readmissions. The next one, of course, readmission. So that metric ties directly into reducing readmission. So this measure will look at reducing all unplanned hospital readmissions with the goal of lowering the overall observed to expected ratio over time. And we've been working on this for the last 10 years. So this is really not new to us. So again, these targets demonstrate that the HEAD model is not only focused on cost, but improving health outcomes. Next slide. Okay, so this is a key takeaway slide because I've talked a lot about financial implications, but there's 4 different components here. Okay, so under the HEAD model, we know there's going to be reduction in Medicare and Medicaid reimbursement. Okay, some of it will be offset by the commercial rates, but again, there will be reduction in reimbursement on an individual hospital basis. The next relates to the commitment to the population health metrics. This will be a statewide metric, but again, it's going to trickle down to your reimbursement at your hospital. And then the quality metric impact, this will be individual hospital. So I'm going to talk about the need for strong quality and care management talent in your organization. And then finally, the choice and competition policies will influence reimbursement at statewide level, but we don't know the financial impacts right now. So I'm going to pause here and I'm going to turn it over to my colleague Linker for our second quick poll question.
Thank you, Laurie. So for your facility, for those areas that Laurie's already covered there, how many of those six population health measures already have an action plan? So A, you're winning. You've got all six. B, 4 to 5. C, 1 to 3. Or oops, none. Or E, honestly, you don't know for your facility provider. So you should see a poll pop up here in just a second. We'll give you about 30 seconds to answer. I'm thinking about mid-range here, Lori.
Yeah, I agree, Linker.
For those that know, and I honestly, if you're coming from another situation or something, you may honestly not know which ones you are. But as Lori said, it's good to be prepared with all these. So just a few more seconds here. We'll see how everyone does. Yeah, looks about in the middle bracket because as you probably noticed, and Lori spoke of, especially with readmissions, we've been working on that for a long time, so not surprised. All right, if we'll go ahead and end the poll, please, and then we'll share that with the audience. You guys should be able to see that now. So about mid-range,
Wow.
and
Yeah,
then on
that's
them. Yep,
yeah.
that perfectly makes sense. Now, Laura, we've
Yeah.
got a couple questions to go over too, real quick. Will there be any changes to which PPS, as in IPPS, OPPS, rules will apply to Maryland hospitals under the AHEAD model?
Yeah, there will be changes, but at this point, Linker, we do not know the exact implications, but it really will speak to staying engaged with the HSCRC and other educational opportunities. But at this point, we don't know.
Yeah, agreed. And I've got one new one that just came in, Jeff here. Are you finding hospitals reluctant to cooperate in early discussions? I'd say from what I've been seeing at the HSCR meetings, it's the exact opposite. You should see all the letters that are coming in, the MHAs there the whole time. Lori, I don't know if you have
No, I
anything to
agree.
add.
I think the purpose of really today is really to start engaging folks and getting them thinking. But from our experiences, hospitals have been engaged and really want to understand it, the financial implications, and what do I need to do, boots on the ground at your organization. I'm going to talk about that in a couple minutes. But one thing that I probably skipped over on the population health is the one statewide measure that is in discussion having to do with food insecurity. And that's one that's up for grabs as far as whether we're going to be held accountable for making sure our patients get the nutritional needs that are required. So more to come on that.
Gotcha. Thank you, Lori. Back to you.
Okay. So we are going to now jump to the next slide. So this focuses a little bit about, hospitals working with your local providers on making sure that we can meet the population health metrics that I just talked about. So local health departments, and hopefully many of you do have good linkages and relationships with your health departments, but local health departments are going to be required to develop their own plans that will address how they're going to help with the state's population health targets that I just talked about. And then hospitals will also be required to develop their own specific population health plans. And again, making sure you align those with your local health departments. So at this point, the takeaway is that the specific template and reporting structure are still being finalized and are under discussion with CMS. So more detailed guidance on how the data collection, reporting requirements, and whether or not your plan is going to be in compliance. So again, it's this collaboration is really to hold us more accountable to making sure that we are collaborating not only with our hospital, but with the public health agencies and community organizations that support our communities. Next slide. So just one brief slide on this one. Again, this was discussed at the workshop back in January. There will be a population health trust. It has been developed. The goal of the fund, again, is to support our population health initiatives. The activities funded through this trust must align with your plans. Again, aligning these incentives the state is trying to ensure that investments in community health are coordinated, data-driven, and focused on improving measurable health outcomes. Back in December, there was a $25 million assessment that went into hospital rates to fund this. And our understanding is that there will be a mechanism for other organizations to contribute to this. So the good news is there is a small pot of money set aside to help us as we're developing these population health programs. Next slide. Okay, so I talked earlier about the Medicare fee for service development. Again, it's in development. We told you that we believe there will be this repricing adjustment that will compare HSCRC to PPS. So it's all in process right now. The expected methodology will be open. This is our understanding for stakeholder discussion this fall with the goal of finalizing this January. So please be on the lookout for how you can participate and give that feedback. Okay. So again, we'll all have some opportunities to provide that feedback during this process. Another important component, and this is actually in the AHEAD model document, is that the program must demonstrate 2.66% savings over the 7-year period compared to 2023. And honestly, we were successful under the other model. I think that we will definitely be able to meet this target. And again, savings target is between us and CMS and help ensure that we can control the healthcare cost growth. If we're successful and we meet that target, those additional savings are expected to be returned into your global budgets, although the specific mechanics are still being worked out. So more to come on that. Next slide, please. Okay, so just want to update you on this component. There is going to be some flexibility and some options to opt out. So, although we've all signed participation agreements to be part of the model, there are mechanisms built into the agreement that will provide flexibility for both an individual hospital and the state to exit this. Individual hospitals can opt out of the Medicare global budget during the 2-year transition period that we're in. And our understanding is the opt-out window is scheduled to occur between June 1, 2027 and September 30, 2027. And this will give hospitals a time to really evaluate whether or not this is going to work for them or for you going forward. The state also has the option to exit the model. And if the state chooses to do so, it will have to provide notice to CMS, and this transition will take several years. Again, once the demonstration period ends in 2025, 2035, 2036, there are several paths forward. And again, this is just a crystal ball. The model could be permanent. We could do another modified or new model, or bottom line is we could just go back to all of us could be part of the national fee-for-service payment structure with no more HSCRC. Next slide. Okay, Linker, we're ready for another poll question.
Absolutely. So,
Okay.
our next poll here for your facility. How prepared do you feel for the AHEAD model after what Laurie's discussed? A, very. B, fairly well, but still some work to do. C, lots of work to do. Or if you've been tuning into the O's pregame or something, what's ahead again for D? So we'll have that poll question pop up and give you about 30 seconds to answer. Once again, I'm thinking shooting for the middle here, and that's what I'm seeing so far. Yeah, a lot of this, as Laurie discussed, many of these programs and everything you've had as your community benefit program for years and years, and things that Maryland has already stressed through the total cost of care model and some other models. So but you're going to have to finalize those. And as we talked about the choice and competition, actually find some things that we haven't done before. All right. So if we want to go ahead and end that poll and share it with the attendees, yeah, so right down the middle. So we've got fairly well,
Yep.
about 29%, and lots of work to do, 71. Yeah. And it's hard to know when you have a moving target. We definitely appreciate that because there's so many things that we do not know yet. And Laurie, we've had a couple questions come in, so I'm going to run those past you.
Okay.
So, how does the model affect the funding for graduate medical education in Maryland?
Yeah, great question. And at this point, there's no indication that that will change. So in other words, whatever is in your global budget will continue until January 1, 2028. But this actually is a question that we've sort of posed to the HSCRC to make sure that this gets addressed with CMS when the model gets implemented in January 1, 2028. So for now, what's in your rates is what you got until then. But if you learn anything more, we will let you know. But no change.
Absolutely. Our next one is it's my understanding this model only applies to the hospitals, not outpatient physician practices.
That is correct. So as you all know, physician and professional practices is outside of the HSCRC jurisdiction at this point. However, there will be this linkage, as I talked about, in having primary care participate with hospitals in the state to make sure that we meet those primary care investment targets, if that makes sense.
Yep, absolutely. All right, Lori, I'll send it
Okay,
back to you.
so I'm in the home stretch. Okay, so here we go. So we've talked about the revenue and payment implications, which is the meat of this presentation, but just some other things to take away. So again, do not sit and do nothing. We've got 18 months to get ready. So really start looking at your billing process and your revenue cycle operations. We all have enjoyed that stability under the HSCRC. We didn't have to worry about different global budgets and different payment methodologies. Again, it was same hospital, same service, same price. But under a head, we have to actually make sure that our billing processes will comply with the Medicare, Medicaid payment rules, particularly as Medicare fee-for-service global budget is implemented. So this means that I know our finance and revenue cycle teams work really well together, but need to be totally joined at the hip. Review your billing systems, review your coding practices and your claims workflows so that they can accommodate those new structures. Also, take a look at your contracts. Under the HSCRC, hospitals had not had to contract with their insurers, but I believe that you really should take a close look at your payer contracts and making sure they're structured appropriately, especially as Medicare repricing and cost shifts begin to occur. Again, hospitals really should begin adjusting your internal accounting models and making sure that new payments that are going to be coming through, that your financial statements will accurately reflect that. And also looking at financial forecasting to reflect the potential for the reduction in Medicare and Medicaid reimbursement. And this will include running scenario modeling to understand the payment changes and how it's going to affect your margin, your service line profitability, and your long-term capital planning. Ultimately, I mean, and I said this earlier, closer collaboration with finance, revenue cycle, compliance, and IT to make sure we're all working together to make sure that we are going to be successful under this model. Next slide. So again, another aspect, another operational step that really you should be looking at is engage with your vendors, engage with your revenue cycle and partners. When I say vendors, Epic, Cerner, Meditech, whoever that does your billing, because they're going to play a key role in making sure your systems are up to date and that your workflow and processes are in compliance with billing requirements. Coding, billing, and reimbursement processes may become more complex. Because of this, I'm going to emphasize this, coding expertise within your organization will become extremely important. We believe that in 2027 that there will be dual coding that will need to occur for Medicare patients. Currently, as you all know, we use the APR DRG system, but hospitals are going to have to get up to speed with MS-DRG coding. So we believe there will be this dual coding that's going to need to happen in July 1 of this year. So please gear up for that. So again, from a financial leadership perspective, investing in coding, staff education, and vendor readiness now will help you reduce any disruption and minimize revenue risk as this model is implemented. Next slide. Okay, so another important aspect to the model is making sure that you strengthen your care coordination. And I know this is a struggle. We all struggle with, we have patients, we're trying to get them out of the hospital, placed with home health, placed with skilled nursing. But again, there will be greater emphasis on managing those relationships to make sure that we can get our patients out of the hospital appropriately, avoiding readmissions, avoiding emergency room visits and readmission. So again, looking at your current relationships are going to be key. And again, refocusing on the relationship with your local health department. Also consider investing in stronger data infrastructure and analytic capabilities. Tracking your quality metrics. Do you know how you're doing? Monitoring your patient populations, particularly those high-risk patients that drive up cost. And managing care coordination, we believe, will require better systems to allow a hospital to measure that performance. Again, engage with your revenue cycle partners and other vendors who can help you track your patients. Next slide. Another area is really to start taking a look at your service mix, your capacity, and how that's going to impact your overall risk. Again, the change in reimbursement as it relates to reduction in Medicare and Medicaid may affect the performance of your product lines. Hospitals really should now look at services that they're providing, and do we need to provide this? Can we partner with somebody else to do this service, especially if it's a low margin service? Hospitals should begin developing contingency performance improvement plans. I know we've all been working on that, but again, it's going to be more critical. And again, policies or these plans may include strategies to reduce cost, consolidate services, eliminate services, forming strategic partnerships, and or eliminating services altogether. Next slide. Okay, so key slide takeaway here. So I've talked a lot today, but as you prepare, here's what we believe you should be doing. Start auditing your billing, accounting, revenue cycle systems. Assure they're ready for the upcoming changes in payment structures. Build and strengthen your care management and population health programs. Making sure you have great connections, great relationships with those folks. And it not only includes, I talked earlier about skilled nursing facilities, but primary care providers that may not be part of your system, other outpatient service providers, behavioral health, your local health department. And these linkages are going to be essential for helping you keep your costs under control and reducing unnecessary utilization. Again, begin those financial modeling scenarios. You're going to be going into a 2028 budget process where your reimbursement's going to be reduced. How are you going to plan for that? So make sure you do those modeling scenarios to understand how that's going to impact your margin, how it's going to impact your budgets. Okay, so scenario model, again, will help you all anticipate risk and make more informed strategy decisions. And then finally, it's really critical, stay engaged with the HSCRC, other state agencies, the health department, as an example, the care commission. What are they doing? Making sure that you take advantage of every opportunity to join those webinars, meet in person, and make sure that you're at the forefront of knowing what these policy changes are going to be and then how you're going to be able to plan for it. So, I mean, we believe that taking those steps early now will position you to be successful under the model. Next slide. Okay, so we put a couple in here, and this is more of an industry outlook, but again, um, it's really again important that the policies, methodologies, requirements are still being developed, and additional guides will come out over the next several months. Again, stay in tune. Again, please begin planning. Don't wait. Don't wait for January 1. It's going to be here before we know it. Again, update and evaluate your billing and financial systems. And I talked earlier about running different financial scenarios, patient tracking with your revenue cycle vendors, and then again, looking at your current service offerings and um, service mix. Next slide. Again, I've already talked about this, looking at your relationship with your skilled nursing facilities, outpatient providers, et cetera. Next slide. Let's see. Forward. Okay, so as the model evolves, we believe we'll see broader impacts across the healthcare industry. I say noise in the market. So according to some insights that we read with HFMA for those who are members, we really believe that we're going to see an increase potentially in merger and acquisition activity. It's been sort of slow, but now we think that's going to pick up because as hospitals and health systems adjust to those financial pressures, organizations are going to need to look at partnerships and consolidate potentially. We believe that we will see underperforming organizations become targets for acquisition, perhaps closure. Larger health systems may look to acquire smaller, struggling organizations as a way to expand their networks. Future acquisitions will focus on non-hospital care, urgent care, ambulatory surgery, other outpatient. And finally, again, over time, please continue to evaluate your service offerings. And then the final slide here is the increased financial pressure on certain types of hospitals, particularly safety net, rural hospitals, as they operate with thinner margins and fewer financial reserves. We believe we'll see slower capital investments in facilities, equipment, infrastructure, which will then mean lower capital budgets going forward, scaling back on major capital projects. And again, as my final comment here is to highlight the importance of strategic financial planning, careful resource allocation, strong partnerships, more critical now. So we are at 12:54. So we have 6 minutes left. And so I'm going to turn it over to my colleague Linker. Any questions from the audience?
Yeah, thanks, Laurie. We do have a couple. I'm going to try to get to as many as possible here. Thank you, everybody, for your engagement. One of our first ones, will the 340B program be impacted?
You
Now,
know
I
what?
don't think,
I
yeah,
don't think so. Linker, great question.
yeah, I
Um,
would agree. There's other things going on, certainly with Medicaid, disproportionate share that may impact it and the way it's calculated. But the head model, not necessarily correct.
That's correct. And let me make a comment on that. The 340B will not be impacted by a head, but I think the 340B is really a political hot potato because it's been, for those who are able to participate in 340B, that that Congress has been looking to get rid of this for years. So honestly, I think it's outside of the head model. I think it's more, within Congress.
Agreed. Next question. What if practices are organizing and assuming total cost of care contracts in one of the ACO programs? Would the head program trump the practices and the funds flow? I know they're trying to keep the ACOs certainly in the program. You may have to change it, the one you're in, I think, but
I agree with that, Linker.
yeah. And let's see. Does this mean that independent physician orgs private equity funding could enter Maryland and contract for risk-based agreements from health plans?
Yes, they're already doing it. So I think the answer is yes. And we we may see more of that happening. Yes, I say the answer to that is yes.
Gotcha. Next one, will hospitals be forced to negotiate with risk-bearing entities like non-health plan groups that hold full risk contracts?
I'm going to say yes and to be determined.
Yep. And let's see, rolling through here. So hospitals would be well served to shift low margin ASC, so outpatient services, to home and community settings and share financial incentives to cover the cost of upskilled home and community-based care services delivery.
I think that's an excellent concept, and I didn't even talk about this, but for those of you who read a lot, there are and maybe some of you are already doing it, where this whole idea of having hospital um, care in the home, and payers are getting on board with that. So, and that's a way to really get, as you know, patients that are in the hospital, that's the most expensive place to get care. And if we're able to move that care into the home, not a home health care, but it's actually a higher level of care in the home. Great concept, which could help us as a state reduce cost.
Gotcha. And I think we got time for one more, Lori. And this is something that I know you and I discussed when we were preparing it. Would CMS be using current MSDRG weights or be behind like the HSCRC is?
That's a great question. I really can't answer that. I'm going to assume that we'll probably try to get up to current. But that would be my answer, is to get up to what's current. But I want to tell the participants today that I've been talking to the HSCRC about the timing of this MSDRG. I talked about dual coding, and I really believe they need to come out and guide us as to what that's going to mean in the timing, and then what quote grouper it's going to be. So,
Yeah. I guess the same with APCs, correct?
yeah, yep,
Yeah.
yes,
Yep.
yes.
Same
I didn't
thing.
even mention APCs. Yes,
Yeah,
yep.
absolutely. I think we're right at time here. So that actually brings us to the end of today's webinar, the AHEAD model, what we know. So thank you again for spending your time with us today. We appreciate it. Have a great rest of your day and go O's.